Welcome to Cozy Talks Live. Sorry, I'm like actually just getting a little comfortable here because it's just one of those long days and I just want to be comfortable. All right, so welcome back, guys. I missed you guys last week. I very rarely will not do a show. I was thinking about that. I was like, these past 7 years of doing the Cozy Talks Live, I can probably count on one hand the number of times that I've missed doing a show. So it's very strange. And it's also strange for my family routine because like Wednesday nights at 8:30, it's Cozy Talks time. So miss seeing you guys last week. We've got Rich coming in from Texas. We got Scott with West Virginia. His allergies whooping up on him. I'm sorry to hear that. Going by. It's good to see you, man, coming in from Miami. We got Emily from Central PA with her Diet Coke tonight. Nothing fancy. Hey there, Chuck. It's good to see you watching me from the YouTube channel. As a reminder, guys, I am broadcasting to my YouTube channel, my Instagram channel, and Facebook pages. Let's see. We got a lot going on here. There's Alex from North Carolina, one of my Tar Heels right there. Haven't seen you in a while, man. Good to see you, Alex. And we've got Chuck here from Wyoming. We got Pamela coming in from New York just with her water. That's all good. Let's see. We got coming in right with those questions, man. We are going to be talking a lot about knee disarticulations tonight, guys, because I had actually several questions come in through the texting and the email services about knee disarticulation. So hang on tight. We're going to be Aho. I don't know how to say your handle name there, but we're going to be talking a lot about that tonight. We got Francis coming in from Orlando. We got Dave there. All right, Dave, I want to hear updates from you. Ms. Delcy coming in from Oklahoma. We got Susan with Marshall. I am very glad that I'm back this week too, Susan. We've got Ed. Oh, man, I got to give a shout out to Ed. Ed is one of my colleagues over at Johns Hopkins. He's a phenomenal physical therapist, a wonderful mentor and friend as well. Thank you for joining in, Ed. I appreciate it. We got Tom coming on board, starting some new, maple syrup season is just starting. Tom, I have been using the beautiful maple syrup to sweeten my coffee. It is like the best thing ever. So guys, we're going to go ahead and get the show started right tonight. Lift up your mugs, your glasses, whatever you've got going on, and your beer stein, whatever it is you got, and cheers to a good evening tonight. So for those of you joining me for the first time, welcome. My name is Cosi Belloso. I'm a physical therapist here in Tampa, Florida. I've been a PT now for a little over 23 years, and my passion is working with the amputee and the limb loss community. And we've got Dan coming in from Kansas City. There's Andrea. She's another one of my colleagues. She's an occupational therapist, and she's saying, no disrespect, but this music gives the "we don't talk about Bruno" vibes. Actually, now that you mention it, Andrea, I'm not going to be able to unhear that. You're absolutely right. See, I was trying to bring a little of my salsa flavor into this show, but it does kind of sound like that, doesn't it? We got Pastor Dave on board, so it's a party started. Yes, it was Ash Wednesday last week, and I did get my ash to church. See what I did there? It's only one time a year. One time a year, I can use that terrible, terrible joke, guys. Just one time. And we got Jody coming in from Vegas. Jody, I'm so glad that you're here with us this evening. I'm really, really happy to see you. We've got Marianne says, I missed you too, man. I really miss hearing from you guys. And we've got a big show tonight. Like I said, we've had a lot of questions because I'm fielding questions from last week and this week. And like I said, a large portion of them from knee disarticulation. And guys, knee disarticulations comprise of about 2% of the amputee population. So it's not a huge percentage of the population. I know in my practice, I've actually seen quite a few knee disarticulations, and I work with them quite a bit. But as a whole, usually you see the most common one is below the knee amputee, followed by above the knee amputee, right? And it's not common that you see a knee disarticulation. We're going to talk a little bit about why that might be. What are some of the advantages and disadvantages of being a knee disarticulation in comparison to a BK or an AK, and other considerations. There was some also chitter chatter on the Facebook support groups as well about this. So it was interesting to kind of hear everybody's stories and chiming in. Let's look at the Instagram channel. We got Michelle coming on board, Angela Abernathy. Angela, I got a lot of PTs on board this evening, so I better behave myself. We've got Earl who says, I'm a knee disartic. It's all I know. So my logic is I imagine having a full femur is great support. The downside is socket fitting, hourglass shape, and how centered my knees are. You are right on the money there, Earl. We're going to talk a little bit more in detail about all of those things. So I really hope you're sticking around. We got One Arm Hugger coming in from Michigan. I love me some Michigan. I'll tell you what, I love Michigan, specifically Traverse City. Heaven on earth for me. All right, guys. So let me just go ahead and start. Okay, so there were a lot of questions, and I'm going to kind of try to take a piece at a time for all the knee dysartic. First of all, let's just go ahead and review a little bit about what a knee dysartic is. I mean, we've heard this expression, but I found one of my slides from one of my lectures here so that you can get a better view. And Bob's a little reluctant today, so he wouldn't be too happy with me if I made him into a knee dysartic. So basically, with a knee dysarticulation, everything distal to the femur is removed. Okay, so a quick little anatomy lesson. You've got your thigh bone, also known as your femur, and your tibia and your fibula, those two bones here down below the knee, right? So the tibia and the fibula are completely removed along with the foot, and then the entire femur is preserved. Okay, so you can see the whole bone is left intact, including this little bulbous end right here. Those are called the femoral condyles. Those are left intact. Okay. Now, there's a couple of different ways that this surgery can be done, and in particular as to what the surgeon does with the patella or the kneecap. Okay. Some will relocate it to the bottom of the femur, and it's called a Gritty-Stokes procedure. Some leave it right in place, right here in the front center part of the femur with the tendon that goes over it to kind of attach it there. Some of it, most surgeons now will remove the patella. They'll remove the kneecap altogether, and then they'll attach the quad muscle, that front muscle on the front part of the thigh, and they'll attach it into the ligaments of the knee. Okay. In some cases, the surgeon might opt to shave down these condyles just a little bit, and that's to help with future socket use. Okay. In general, a knee dysarticulation is considered to be a relatively simple procedure in comparison to above the knee or below the knee. Okay. And there's less blood loss involved in general. Okay. Some of the advantages to the knee dysarticulation is that it has a longer lever arm. Okay, so that's kind of, those of you who have been amputees for a long time, you know how the physics of this works, right? The longer your residual limb, the longer lever arm you have, and the more of a mechanical advantage you will have with walking. Okay, and then in addition to having a longer lever arm, it also means you have more muscles that are longer and more intact, more preserved in general. Okay, so that is the general rule of thumb, right? The longer your, right screen. Okay, so the longer the amputation, the more functional mobility the person will have. Okay, so like I said, knee dysarticulation kind of falls in the middle. It's not an above the knee amputation. It's not completely a below the knee amputation. So do they have an advantage? And if so, how? Okay. Now, much of what I'm going to tell you tonight is just based on the 23 years I've been practicing and working with all the different levels of amputation. Okay. When it comes to knee dysarticulation, I think they do have a much greater advantage compared to above the knee amputee. Okay. Because of that lever arm. Okay. Here's another thing about a knee dysarticulation patient. Okay. They're also going to be able to bear weight at the end of that femur. Okay, so let's go back to that little drawing right there. Okay, right here, they're going to be able to put weight directly into it with the socket. Okay, so that's going to give them a little bit of an advantage when they're walking. Okay, and then on top of that, this bottom part is basically nicely anchored. Okay, so do you guys see how the femur bone, that thigh bone, is angled in just a little bit? It's not like just sticking straight down. That's how it was meant to be. You can see in this part of the limb over here, guys, right? That femur is angling in just a little bit, and that's what we want. Now, when you have an above the knee amputation, meaning that the surgeon cut this bottom part of the femur off, right? This part of the femur will tend to fishtail, right? And we've talked a lot about these complications on the show, right? For those of you who are traditional above the knee amputees, the challenge with your prosthetist is how to secure that fishtailing femur bone, right? Because it's going to go, if it's not well secured in the socket, that femur bone is going to go flip-flopping around in there. Okay. So when the person has a knee dysarticulation, I mean, that bone is anchored down and it's angled in and it's not going anywhere. It's a much more stable setup in that regard from a socket standpoint. Okay. So in those cases, they tend to be very, very mobile. A lot of times, especially if I have someone who's, on the younger side with a knee disarticulation, a lot of times they really function like a below the knee amputee, almost, right? They're still having to learn how to use a knee and a foot. Okay. So it's a fine line in between there. Okay. Marianne says, I got my Ash toucher last week too. Good. Hola, comadre. Good to see you, mama. All right. Emily's cousin lives around Traverse City. I love Traverse City. Love it, love it, love it. So Delcy says it's extremely hard to find a prosthetist who has experience building a socket for a knee disartic. The socket design is crucial. It is, but it's not impossible. And it's sad because some of the questions that were sent to me by knee disartics, they were saying, my prosthetist doesn't seem to know how to fit for me. And granted, we got to cut them a little grace. It's less than 2% of the amputee population. But guys, I could easily name to you here in Tampa 3 prosthetists off the top of my head who are very well versed in fitting knee disarticulation patients. Is it a greater challenge, I think, for a prosthetist? Yeah, it's a little bit more challenge, or not more challenging, but it has its unique challenges, right? Because to me, an above the knee amputation is also a challenging fit because you got to stabilize that femur and make that socket comfortable. Okay. One of the biggest things when it comes to making a socket, and again, if there's any of my prosthetists are on board this evening, I'd love to hear from your standpoint as well. When it comes to the creation of the socket, is accommodating, right? Accommodating that bulbous end. But once you're past that, it's a pretty nice little fit. And then also you have to accommodate the center of the knee, right? Because you don't want to have the knees one lower than the other. So alignment is also something that has to be taken more into consideration when the person is a knee disarticulation patient. Okay, I just want to make sure I am getting all the people from Instagram. By the way, my Instagrammers, if y'all want to put in a question in the comment section, don't be shy. Go ahead and do so. Okay. Now, when it comes to getting that bulbous end in, I love the use of what's the word I'm looking for? Adjustable socket. Okay. And y'all know that I'm partial to the Click Medical RevoFit system. So one of the ways that RevoFit system works is it's an adjustable socket. So it can open up. And I think my adjustable socket model is at the clinic because I was showing a patient the other day, a sample of that clinic. So basically with this adjustable socket, it can open, allow the limb to go all the way in and then shrink up. Okay. And allow for a good, stable fit. When it comes to the build heights and things like that, someone mentioned that. Are there limitations? Yes, there's going to be certain limitations because there's only, you have to accommodate for build height. And again, this is where I would love to have a prosthetist by my side to talk a little bit more about that. Okay. But you do have certain limitations with certain knees. But like I said, guys, I've never really run into a knee disarticulation patient that had a good prosthetist that they couldn't find a solution that would work for them. Does that make sense? So Delcy says with a knee disarticulation never be aligned, at least that's what I've been told. I can't say that I agree with that. I mean, your alignment is going to be pretty crucial, right? And they have to adjust what's called, they call it the TK line, the trochanter knee ankle alignment. So it's a line that is used to help balance the prosthesis and balance all the gravity and forces acting upon the body, right? And that is something that is taken into account. Okay. So with a knee disarticulation patient, especially if it's someone who is young and has good mobility, you can actually set them to be less stable. And what do I mean by that? What I mean is that they're able to have more freedom with their knee. Okay. Or if the person is someone who is not really good with their mobility, perhaps someone who's a little bit more elderly or someone who's just been really declining in their function, they can set the knee to be more stable. Okay. And this also applies, guys, for the above the knee amputee. So when it comes to alignment, it's really a fine tuning Goldilocks process. Okay. And it's unique. It truly is unique to every individual, And it does take trial and error, whether you are a knee disarticulation or an above the knee, and even with our below the knee amputees. Okay. So again, if you're those of you who are really not finding any success with the current prosthetist that you're with, I would encourage you to get a second opinion. Okay. And if it means having to perhaps leave your zip code, if you feel like there's nobody in your area that can do this, I would encourage you to start looking outside your zip code. Even if it means having to travel just a little bit, I promise you there are wonderful prosthetists out there who are very well versed with knee disarticulation patients. Okay, and those of you who have watched my show for more than 5 minutes, you know how much I advocate for the importance of having a good relationship with your clinician, whether it's the physical therapist or the prosthetist. All right. Oh, Glenn's on board. Oh, yeah. Cheers, Glenn. And Mark. I've got Mark on board and everything. Look how pretty, guys. My son made me my favorite decaf coffee before the show started. Isn't that sweet? All right, we got Brian Bishop. Brian, I hope you got your café con leche right now. Better late than never. I hope it's because you were making yourself a cup of coffee. All right, let's keep talking a little bit more. Let's see. Okay. So this is one of the questions that I was tagged in one of the support groups, and it says, how close to the knee can I have my stump? Right now, it's about 5 inches below the knee, and I've had 2 revisions, but my surgeon thinks he may have to go above the knee for good tissue. I'd rather keep my knee. So how close can I possibly go and still be functional with a prosthetic? So this was, again, I was tagged in on this question. And by the way, guys, just so you know, if you guys see a question on one of your Facebook support groups that you're like, hey, this would be a great question for Kosi to answer, go ahead and feel free to tag me. I'm happy to answer those questions and also bring them onto the show. And I keep it anonymous who it was that posted it. So in the case of this gentleman, and this is something I've run into in several occasions, where the person was already a kind of short below the knee amputee, and for whatever reason they were facing a revision. So what's a person to do? Okay, obviously at the end of the day, the surgeon is going to have that final call. Okay, if the surgeon is stating that there needs to be a revision, usually it's because there's compromised soft tissue. There's something going on with that soft tissue and it's not healthy anymore, or the bone is not healthy. Something is not well and it needs to go. Okay. So if the surgeon is talking about converting you from a below the knee to an above the knee, okay, the questions you need to ask are, what is the reasoning? Okay, have them explain to you, what is the reasoning for taking such a drastic measure? Okay. And again, guys, for the most part, surgeons, awesome people, wonderful human beings, really good at what they do. But sometimes you might find a surgeon who perhaps is not as well versed with amputee care. They might be a very good surgeon, but perhaps they only see the occasional amputee every once in a while. So it's good to ask these questions. Ask your surgeon, what is your reasoning for taking me above the knee? Because in losing that joint, yeah, it's going to change quality of life, mobility drastically, right? Okay. So if the surgeon is saying, I want to get good, healthy tissue, okay, that's a very reasonable answer. The next question would be, what is the absolute minimum we can get away with? Okay. Especially when you're that close to the knee already. Okay. And one thing I would ask this individual is to ask your surgeon, can I be a knee disarticulation patient? Okay. And believe me, if you say this to a surgeon, they're going to kind of look at you, like, what? Right. Because again, sometimes the surgeon will say, well, you're going to have a lot of issues with your prosthesis. You're going to have a lot of issues with fitting. You're going to have a lot of issues, right? And then I would encourage you to say, yes, but is it something that we can consider? Okay. The answer might be no. You may not have enough good, healthy tissue to be a knee disartic, and you may, in fact, have to go to being an above the knee amputee. But if you see that your surgeon goes, okay, again, this is the point where I would encourage you talk to your surgeon and then bring the prosthetist and bring the physical therapist into the conversation. Okay. When it comes to revisions, guys, and even when it comes to the initial amputation, unless it's a life-threatening issue, like you're septic and you need that leg off now, or you need that revision now, if there's a little time to plan and to consult, even if you just have 24 hours, guys. I had one guy, a friend of mine, short detour on this conversation. I had a friend of mine about a year ago, and she called me and she said, Kosi, my dad's in the hospital. His foot has gangrene and they want to amputate him and make him a below the knee today. I said, whoa. So she calls, of course, she calls me because she knows what I do. And I just said to her, my first question to her was, is your dad's life in danger right now? And she said, no, he's actually very stable. Even the surgeon has said that we've got a few days. And I go, okay. So what you need to do is you need to get a second opinion, because she had described the case to me. And I just said, below the knee sounds very drastic, very, very drastic. At most, maybe the toe, but this is sounding very, very, very drastic. And I couldn't lay my eyes on it, but I said, you know what? Let's bring somebody else in. And thankfully, my friend, she's very assertive, and she advocated for her dad, and she had her dad transferred to another hospital the very next day. And that surgeon took a look at her dad and said, no, he does not need to be a below the knee. We actually just need to change up his wound care. And they saved his leg. Okay. Now, not all of our stories have happy endings like this, but it was even a shock to me to say, wow, I'm so glad that she pursued that and getting that second opinion. And Ed right here, my colleague here, is saying PT, CP, and physiatrist, multi-team approach. Absolutely. And that comes for when you are a knee disarticulation patient and there might be certain complications there, but especially if you are looking at that revision. Okay. So Ed says the physiatrist can talk to the surgeon and be heard. He's absolutely right. He's absolutely right. You guys remember when you were kids that if you really wanted something and your dad said no, sometimes you'd go to your mom or sometimes the opposite. For me, it was usually my mom saying no, and I would go through my dad to try to get what it was that I want. Okay. If you apply that analogy to the medical team, right? As a physical therapist, if I feel like the surgeon is perhaps we're having trouble communicating, I might go to the physiatrist and say, hey, do you think you can talk to the surgeon about this idea that we have or this suggestion that we have? Okay. I have to admit, physiatrists are some of my favorite physicians, probably because they're just so closely related and work so closely with the rehab team. But Ed is absolutely right. When it comes to these kind of decisions, especially when it comes to revisions and the possibility of taking someone from a below the knee to an above the knee, it's a decision that should not be taken lightly. It really should not. And again, unless it's a life-threatening issue. Okay, and this goes out to my younger clinicians as well. And you feel like there is a possibility of either staying a below the knee, okay, and having at least 3 inches there. It's not very much, but it can be just enough for a good prosthetist to get a socket on. Or if below the knee is completely out of the question, just try to keep it as a knee disartic. It's something that I would definitely explore and get the whole team involved to make it a group decision like that. Yeah? Okay. So let's see. We've got Steve coming in from New York as well. We've got Linda from New York. We got a lot of New Yorkers here on board. We've got Harsh coming in from Virginia. And let's see. Emily says a second opinion saved my right leg. And Christine's giving Tom a hi. All right, let's just check over here on Instagram. It's awful quiet. Y'all Instagram folks are quiet. Y'all need to liven it up just a little bit. All right, so let's keep going with the questions. So we had some really, really good questions. By the way, who on here, if you guys don't mind, like saying, who here is a knee disarticulation? Knee disartic. Okay, so let's keep going. And actually, there was one prosthetist who chimed in on this particular question about the person going from a below the knee and how short they could go. And this particular prosthetist said, at least 3 inches below the knee is an absolute minimum, maybe getting away with 2.5 inches. And then what would have to happen is you would have to take into consideration a little bit more aggressive suspension. So the trim lines would have to be just a little bit higher. The guys, in my humble opinion, I truly think that when it comes to keeping the knee, I tend to favor keeping the knee at all costs, making sure that that is what is the safest for the patient, meaning their tissue is healthy enough and they'll be able to handle that surgery and it'll have a good outcome. A note about the patella, okay, because there was somebody here, one of the questions that I've had, and I've had this question in the past as well, should the patella be left in? Okay, the patella, the kneecap. Okay. From what I have been reading, and again, when I think about the patients that I've seen over the years, I very rarely, I'm trying to think if I've ever seen anyone who's had their patella left in. I know in Europe they were leaving it in at some point in time. But for the most part, it's removed. And here's why. What some of the studies were showing, well, originally thought process behind the surgeon was that if they left the kneecap in, then the kneecap could be like a little weight-bearing platform, for the person. But what they found was that that bone on bone ended up causing a lot more problems down the line. Okay. And actually, now that I remember, there was a young lady a few months ago that she wrote in and she said, I still have my kneecap and it's causing me a lot of pain. And nobody wants to address this. And I just found that so strange, because all the surgeon would have to do, well, not all the surgeon would have to do, again, I'm not the surgeon, but if it's a matter of removing the kneecap and just retacking down those tendons, why aren't they looking at this? So if that is a part of the conversation, the other part of that conversation has to be what surgical strategy is going to be used. Are they going to leave that kneecap in, which is not recommended, or are they going to remove that kneecap? Okay, so Delcy says, I'm a knee disartic. Okay, so here's another series of questions. Okay, so this question had a lot of segments, so I'm going to take it segment at a time. A lot of good information though here. This particular individual lost her leg in 2021 due to a motorcycle accident, had a lot of injuries associated through it, and is now a knee disarticulation. And she is constantly being told that she can't do all the things, that she cannot have a specialized foot and cannot have a specialized knee. No, that's not true. First of all, not true. There's hundreds of feet out on the market and dozens upon dozens of different knees. So I'm not sure what they mean by you can't have a specialized knee. You most certainly can have a specialized knee. I've seen some people who have a mechanical knee and they do wonderfully with it. I've seen some people who have a microprocessor knee. Like I said, is it a little bit more limited? Yes, because you have to take into account the build height, and you're not going to have as much build height as someone who has an above the knee amputation. Okay. But you have options. Okay. I am told by my prosthetist my limitations, like I can't have a specialized foot, can't have a specialized knee. I cannot do all the things that an above the knee or below the knee amputee can do. Wrong. Here's one thing a knee disartic can do better than an above the knee. They can run better. To me, that's where I really see sometimes, and Ed, if you're still on, I'd love to hear your opinion on this one as well. A lot of times when I see a knee disarticulation, if they're a candidate for running, they pick it up beautifully. They have to work on it, right? They have to learn how to maneuver that mechanical knee, but they do a great job. They really, and it always amazes me, because I'm just like, wow, technically they don't have an anatomical knee, but looking them run. I mean, I'm thinking of one gentleman I know, his name is Jeff. He's pretty active in the community. He's a knee disartic. And I remember him sending me a video of him on the treadmill, and I'm just like, holy cow, you run super well. And I'm like, oh, right. He's a knee disartic. He's got a nice long lever arm. Okay. There's actually some mechanical advantage there, for this individual. Ed says, keep the knee at all costs, if feasible. Yes. And it's always that, if allowed. Okay. But if your surgeon is telling you here, and again, I always hesitate when I say this, because I'm just like, I'm going to have some surgeon coming back and angry at me saying, you're not a surgeon. You shouldn't be saying these. If the surgeon is telling you that the reason why you have to be an above the knee is because you're not going to find a socket that fits and you're not going to be able to use a prosthetic knee well, wrong answer. So just putting it out there. And this is where you would politely go back to your surgeon and say, I can find a prosthetist who can make me an amazing knee disarticulation socket. Okay. If that's the only reason they're going to make you an above the knee, then fight for that knee disartic. Delcy says, I've been told by 6 prosthetists that I cannot have a running blade due to being a knee disartic. Yeah, no, that's not true. No. And again, I don't want to be, I'm not going to, it's easy for me to play Monday morning quarterback and be like, what were these prosthetists thinking? But I'm not going to try to do that, guys. Okay. I've had knee disarticulations that run. They can run. Okay. Again, is it a little more challenging to find a foot and a knee and a running setup? Yes, you're going to have some particular challenges, but is it impossible? Nope. Nope. I wish I had that video of the gentleman that I just referenced right now, Jeff, running with his running blade, because he's a knee dysartic himself. And here's the reason why behind this, Delcy. No, but the build height can also be done. And again, this is where I really wish I had a prosthetist sitting next to me. One of my prosthetists sitting next to me, the ones that I know that know their knee dysartic stuff, to talk a little bit more about this. It is possible. Is it a challenge? Yes, but it is still possible. Okay. And the thing with running blades and running sockets and running alignment, it's very different than a socket that you walk in. The alignment is different than what you would normally use for walking. Okay. And again, even in Tampa, Central Florida, okay, I know a lot of prosthetists. There's a very small handful that are well versed in running alignment. Okay. Because it's not something that they do very often. Okay. I mentioned that knee disarticulations comprise of less than 2% of the amputee population. Okay. Amputees who are candidates for running, meaning I'm not just talking about running to get away from danger, running to get away from the tiger, running to go after your kid who's going in the street. I'm talking about dedicated running that requires a running blade. It's a very small percentage of the population. Okay. And I'm not talking about people, amputees being athletes or being active. A lot of those activities are done with non-running blades. Okay. But so, you can imagine then that not very many prosthetists will see someone who can be fit for a blade. Okay. Much less a knee disarticulation who is capable of running as well. Okay. So again, Daisy, no, it's not necessarily well, okay. Are there certain lazy clinicians out there? Yes. PTs, prosthetists, it exists, right? But a lot of times it just might be that they are not familiar and they're simply not trained. They're simply not trained. Okay. Let's see. Sorry, I'm kind of reading this. Okay, so again, when it comes to this individual apparently has the patella still in. So Delcy is saying my amputation was done in the ICU. The patella was left in, but it's hanging out in the left side of my femur, pinching a nerve. When I sit down, my knee dysartic does not touch the floor, only my sound leg. Okay, so yeah, it sounds like you've got some things going on there. And again, one thing you might want to consider, and I don't know if you've done this since, is going back to the surgeon and just asking them if they could give you a consult on a possible revision to remove that patella. And just see what they have to say about that. If that is something that you would be a candidate for. And again, Ed is saying you, Mark, and Delcy need to talk, promise. Delcy, if there is a prosthetist who could make you an amazing knee disarticulation prosthesis, I can't talk this evening because I haven't had enough of my coffee. It is Mark Hopkins. Absolutely. Absolutely. Ed, can we put Mark on the spot just a little bit right now? Can you put in the comment section the name of his clinic, if that's okay? I don't want to like ruffle, I ruffle feathers all the time, so that's nothing new for me. But if you feel comfortable, Ed, would you mind putting in the name of Mark's clinic and the town that he is in? Because there's people who need good prosthetists, and I'm always in favor of making good recommendations. And Mark is somebody I would recommend with my eyes closed, truth be told. So Delcy said, I did have 3 consults and they will only do it if I become an AK. Okay, so I guess my question, Delcy, would be is why did they say this? And again, I am not a surgeon at the end of the day, and I have not seen your leg. So it's very easy for me to say, yeah, just take your patella out, take your quadriceps tendon and reattach it to your ligaments there, and off you go. But again, what is the reasoning that they're telling you this? And that would be my next question, is to see like, okay, well, why? Why? Sorry, guys. Okay. I had a lot of questions, guys, so thank you for being patient with me. I think we covered a lot of the questions actually from the knee disarticulation standpoint. All right, Here we go. We've got quite a few people joining in on Instagram as well. So, guys, welcome again. Okay. So, moving on to another question that I got. Okay. This person asks, do you know of any amputee rehab specialist in the Orlando, Kissimmee area? I'm really having trouble finding a therapist that will help me with my gait and therapy. Okay. So Delcy says, great question. My femur was shattered. The distal end is still not joined after 3 years. Okay, so Delcy, this kind of helps put the puzzle pieces together. If your femur were completely intact, right, and stable, then the removal of the patella, it's really not a big deal. It's a sesamoid bone. It's considered a sesamoid bone, and that just means it's a bone that just is floating, right? That's why when you look at your patella, you can kind of wiggle it around because it's just kind of floating, right? So if the rest of your femur were stable, then literally it would just be a matter of picking out the patella and then attaching the tendon back. Okay. So if the distal end of your femur is shattered and it's not in good shape, okay, then that means that perhaps the surgeons are seeing something there that means that it would not be stable. Okay. Again, it's easy for me to play Monday morning quarterback, but whatever decision you decide to go with, if you decide to try to continue to pursue finding a prosthetist who can work around your current situation, or whether you decide to go with a revision, and become an AK. Again, make sure you have all those questions answered. Okay. And again, Delcy, I would love to connect you with a prosthetist that is well-versed in making knee disarticulation prosthesis, and just trying that route just to see if they can work around what your current situation is. We got Earl coming in from California. Okay, so going back to this particular gentleman from Orlando, and guys, those of you, just a quick lesson in Florida geography, Orlando is about an hour and a half, 2 hours max if you're coming in like the really, really bad traffic. It's anywhere from an hour and 15 to 2 hours. Let's just put it that way, from Tampa. Okay. And again, I'm not picking on this gentleman. This gentleman is a very, very sweet individual, and I'm not picking on him. I'm just kind of using this as an example. Unfortunately, there are not very many of us as physical therapists who practice working with amputees. Okay. A couple of you guys have called us unicorns because we're not very common. And for several reasons in my profession, we don't have a lot of PTs who specialize in amputee care. Those of us that do, people like me, people like Ed, people like Andrea, people like Michelle, and a couple of other people listening in on Instagram, we are rabidly passionate about working with amputees. We are all into what we do. Seriously. Like, you want to talk about some of the biggest nerds in my profession, talk to an amputee specialist. Okay. For whatever reason, we love, not for whatever reason, I know why, we love what we do as amputee PTs. Okay. And we dedicate our careers and our professions to learning everything we possibly can about this specialty. And I got to shout out to the rest of my colleagues that go into the specialties such as pediatrics, specialties such as women's health, specialties that they really niche down into these specialties in their careers. They tend to really become experts in what they do. Okay. So I guess what I'm trying to say is, if you have a physical therapist, okay, that is within driving distance, or even perhaps a short trip from you, okay, who is experienced working with amputees, go see that PT. Okay. Now, I obviously understand, and again, I am not picking on this lovely gentleman who texted me, but for whatever reason, there perhaps might be transportation issues. Perhaps this gentleman cannot cannot drive, perhaps does not have transportation. Okay. But guys, since I opened my practice 7 years ago, I've seen people do some incredibly creative things to get to my clinic here in Tampa. And likewise, my colleagues around the nation who also hang a shingle and say that they work with amputees, they've had some amazing stories of people that you're just like, I don't know how in the world you managed to get here, but you got here. So we're going to work with you. We're going to do everything we can to get you mobile. Okay. And again, those of us who specialize in this, we do see a lot of out of town or out of state patients. Okay. A lot of, I'd say half of my practice is out of state or out of town, outside the Tampa area. Okay. And I work with those patients and I try to figure out, okay, if this patient is only here for 1 day, 2 days, maybe 3 days, what is the maximum amount that I can give this patient? And then what can I do to prepare them so they can have continued success when they go home? Okay. I've gotten real creative as far as, continuing communication with their physical therapist at home, especially if that PT does not have amputee experience, and how can I consult and guide them through the progress. Okay. And again, a lot of my colleagues will do the same, guys. A lot of my colleagues will do the same. So, when I had to chuckle a little bit because, the gentleman's in Orlando and I'm like, you realize you're right there. For me, that's being right there, So for some of you, and I'm kind of gently nudging at some of you who have asked me for references, and I've referred you to a physical therapist. And yep, might be an hour or two drive, but again, if you have transportation, or if you even invest in just going once a month or once every 2 weeks to go see this therapist, guys, I promise you, you won't be disappointed. It truly, and again, I'm not just saying not me, I'm just saying PT in general who specializes with amputee care, it means sometimes the difference between being able to walk and not. Okay. So just kind of putting this out there as much as I can. All right. Mark says, take a drive to see Cozy. Yes. I love seeing people. All right. Paul says, good evening. There may have been some Jamesons in my coffee mug. Well, speaking of PTs, there's another one of he's one of my OG mentors. Right there, guys. I'm going to embarrass Paul just a little bit because, he's going to start heckling me at any minute now. So I got to get in first. Paul was one of he is the therapist I credit for making me the PT I am today, for better or for worse. So I'm going to give Paul a shout out tonight. We got Mary on board. Greetings. Hey, better late than never. Happy to have you, Mary. Let's see. All right. Tammy says, I'm going to have a revision. I've been an amputee for 23 years. I'm right below the knee, have a lot of loose skin and vaginated scarring, skin induration. Yep. Doctor said I really don't have a myodesis now. I saw a physiatrist first, then I brought my prosthetist to my appointment, orthopedic surgeon. They're hoping to have enough healthy tissue to create a myodesis without making my legs shorter. I like this. There's a possibility I may end up with a knee disarticulation amputation. Right now, I cannot get a good fit at all. My skin shifts too much and my height changes, and I can't be active due to the pain. I wear my leg 14 to 16 hours a day. So Tammy, if you don't mind my using you as an example, guys, this is a prime example of when things are getting to a point where you have to consider a surgical consult. Obviously someone like Tammy has been an amputee for 23 years. So she's been an amputee for as long as I've been a physical therapist, right? So I'm willing to bet there that she has been there, done that, tried everything with prosthetists. I love the fact that there's a surgeon involved, there's a physiatrist involved, and that you brought your prosthetist to your appointment with an orthopedic surgeon. I don't know who your prosthetist is, Tammy, but I want to meet that prosthetist, and you need to hang on to that prosthetist for dear life. If they're coming with you to your surgical appointment, gold right there. So let's talk a little bit about what she's talking about with the myodesis and everything going on. So as a below the knee, it sounds like there's a lot of loose skin, invaginated scarring. What does that mean? It's kind of like when the skin turns in and it creates like a valley or a crevice in the skin. Sometimes these invaginations can be shallow and sometimes they can go really, really deep, right? And it can cause a lot of problems with skin breakdown, with chafing, with blistering. Some people have no problems and the prosthetist will work around that invagination. And in some folks, it just over the course of time and gravity taking effect, those issues can become more pronounced. Okay. And then on top of that, I like that they're talking about the myodesis. So let's talk a little bit about what is a myodesis. Okay. There's a lot of different surgical strategies for amputation, right? So how they treat the soft tissue, that's kind of what's going on the inside, right? So there's two main surgical strategies. There's what's called a myoplasty, where they take the end of one muscle that's been cut and they suture it to another muscle that's been cut, and it's like a muscle sling and it goes over the end of the bone. Did I bring my sketch pad? No, I did not bring my sketch pad. Sorry, Andrea. Okay. So it goes over the end of the bone. Okay. And that's usually in cases where the person does not have very good blood supply and the surgeon wants to make sure that that tissue stays healthy. Okay. Now, the problem is if it doesn't heal properly, that muscle sling over time is going to snap over the end of that bone. And we talked about that on the last show from a couple of weeks ago. Okay. With a myodesis, okay, the surgeon takes the end of that muscle and attaches it to the bone itself. Okay. And then what the surgeon tries to do is they try to attach those muscles to the bone in a similar alignment as to what it used to look like. Right. So the quadriceps in the front, hamstrings in the back. Okay. Your abductors and your adductors and everything else. So they try to kind of sort of preserve similar anatomical alignment in those muscles. Okay. So with the myodesis, it's attached to the bone. So the person has to have good circulation in order for that to heal properly. But it's also a better outcome because then the muscle, when it's contracting, it's pulling on bone, which is how it was always meant to be. Okay. Now, I like the fact also, Tammy, that they're considering a knee disarticulation, that they're not just telling you, okay, if this doesn't work, then you're an above the knee amputation. Okay. So I like the fact that they are having this conversation. And just from the one sentence you told me about your prosthetist coming to your appointment with you, I'm willing to bet, my lunch that this prosthetist is also someone who knows how to make a good knee disarticulation socket. Okay. And yes, when your skin is shifting that much as a below the knee amputee and you have all that excess soft tissue at the bone or at the bottom, it's really hard to get a good stable fit. And even with the most skilled prosthetists. And the fact that you are in pain all day and you are somebody, 14 to 16 hours a day that you're wearing your leg. So Tammy, I truly wish you the best of luck with this procedure. And if you don't mind, I would love to hear how it all goes for you. But I can say that I'm happy to hear that you have an amazing team behind you. So guys, let me just take a minute right now. Okay. So the email address that I listed is my own email address for my business. And this show is for you guys. And I say this a lot. This show is for the amputee community. So that's those of you who are amputees, your clinicians, your caregivers, and family members. So any questions that you have, feel free to submit them to cosi@cositalks.com. The other way is that you can text me directly. Okay, and I'm writing down exactly how you can do that. And many of you are starting to use the texting service more, and I really, really like that. It makes it very easy for me to get all those messages in one place. So guys, if you text COSI Talks, all one word, all capital letters, just like that, to that number, you will be signed up for my texting service. I promise I do not spam people. I don't sell your number, none of that nonsense. I send you one text per week, and that's on Wednesday nights right before I go live. And I will send you the links to my show. So it's a little easier to find my show. Sometimes I'll also text you saying, hey guys, here's some giveaway information. Hey guys, come send me your questions. But I promise I don't get obnoxious with the texting. So if you guys want to text me your questions, feel free to do so. Okay, let's keep talking. My pleasure, Delcy. Right. And again, Delcy, it's asking questions. And again, just to keep in the back of your mind, it's easy for me to say, well, they should be doing this and they should be doing that. But again, just ask why. If there's something that you don't understand about the reasoning behind it, ask your surgeon, ask your prosthetist to explain why. And they should be able to explain it in terms that you can understand, even if you're not a healthcare provider, right? Mark, you're awesome. I miss seeing you, Mark. Dave says, you talked me into driving a long way. And you're going to call me and you're going to thank me for it. I promise you. My girl, Michelle, is amazing. Ginny says, time got away from me today, so I'm late, but hi, Ginny. I am sending you a big hug today. And I am so glad that you're with us this evening. Please show me where the abductor is. Mark, I'm not that kind of girl. But Bob is, or Guy. We don't know. Oh, Bob, what happened to Bob? Okay. I don't know. Maybe I should probably feed my kids more often because poor Bob here looks like he's getting gnawed to pieces. Okay. So there's a few different abductors in your body, Mark. Abduction, abduction. Here, let me just write that down because it just sounds funny sometimes. Abduction simply means moving away from the body. And it comes from, and this is probably one of the one or two things I remember from my Latin class, that prefix ab means away, as opposed to adduction. Okay, I'm going to write that down. Adduction. And that prefix ad means to. So if a physical therapist is talking about abduction, telling you to abduct your arm, they're telling you to move your arm away from your body, from the midline. That's how we reference it. If they're telling you to adduct your arm, they're telling you to move your arm towards your body. So some of the movements that we talk about in the body, we talk a lot about shoulder abduction, shoulder adduction. Bob, you got frozen shoulder, man. I can't move your shoulder enough, right? Okay, so when we talk about an abductor, we're talking about the muscle that causes abduction. Okay, yeah. Okay, so your deltoid would be an example of an, and we'll say abductor. So your deltoid is that nice little muscle that I need to work on right here, right? It helps to abduct your shoulder. Okay, now abductors are a favorite source of discussion for me as an amputee physical therapist because they are the muscles that help stabilize your pelvis and your hips. So when you hear me talking a lot about those muscle stabilizers in your pelvis, I'm referring a lot to your hip abductors. So the hip abductors help, right, this movement. So moving the hip away from the body, right? And it's a muscle here. It's right underneath your gluteus maximus, and it's called your gluteus medius. And there's a few other muscles also involved, but that's one of the big ones right there. So your gluteus medius, Mark, is right there in your bum, right underneath your gluteus maximus. Many NBA players get hurt in that way. Yeah, they get hurt in lots of ways. Mary, oh, well, I'm glad to see you here. All right. Okay. Oh, here's one. Emily asks, I feel like I'm constantly slouching in my wheelchair. I'm not wearing my prosthesis right now, so I can't push off to scoot myself further back in my wheelchair. I don't have a lot of strength in my other leg. I just try to use my arms and upper body to help me scoot back into my wheelchair, but I feel that only works for so long before I start to slouch again. Are there any exercises that I can do to keep this from happening? Some kind of core exercise or something? Yes. Sorry, guys. Just checking real quick on Instagram. Okay. So when it comes to someone who is who's using a wheelchair a lot for their mobility and they're spending a lot of the day in the wheelchair, it's very similar. You know, there's a lot of considerations that are similar to someone who is a paraplegic or a quadriplegic, right? When they are wheelchair bound for all of their mobility. Okay. A lot of people just think, oh, they just sit in their chair all day and that's it. It's like, no, actually there's a lot that's involved, from the shape of the wheelchair to the alignment of the wheelchair to the wheelchair cushion to how the wheels are designed to the width of the chair to the depth of the chair. I mean, just in the chair alone, there are a lot of details and factors that are taken into consideration for someone who's going to spend the majority of their day in the wheelchair. Okay. Now, why is this? Why do we care so much about the wheelchair and how it is designed and everything like that? Because there's a lot of risks for skin breakdown. Okay. When I was working, I worked several years in the spinal cord injury unit. That's actually where I met my buddy Paul, who I think he's hiding from me right now. Okay. I was taught it takes 20 minutes for a pressure ulcer to form. 20 minutes. That's not a lot. Okay. And then for someone who's a paraplegic or a quadriplegic, that they're not going to have sensation in their bottom. They're not going to have sensation in their hips. They're not going to have sensation on the back of their legs, the back of their knees. They're going to be even more vulnerable, right, to a pressure ulcer. Okay. So when I work with someone who's an amputee who spends a lot of time in their wheelchair, I have the mindset of, okay, bringing in some of that training that I used to give to the paraplegic and quadriplegic patients. Okay. So first of all, Emily, you're not meant to just sit in your wheelchair in the same position. You should be constantly moving. Okay. And guys, next time you're out in the community and you see someone who is a paraplegic and even some quadriplegics, just take a minute to observe, and you're going to notice that they're very twitchy, right? A lot of times you'll just see them fidgeting, right? And the more control they have over their bodies, the more you're going to see them fidgeting and moving. And what they're doing is they're purposely shifting their position all the time to making sure that they have circulation on their bottoms, to make sure that they're not having any pressure points. Okay. So this is something that Emily, you need to take into account. First of all, you need to have someone take a look at that wheelchair and just see like, okay, what is going on? If you're spending the majority of your time in that wheelchair needs to be accommodated for this. Okay. And if you're constantly slipping out, then yeah, there is something not right, whether it's the cushion that's not right, whether it's because maybe it's perhaps too shallow, whatever the case may be, it may not be the right sizing for you. You need to have that addressed. Okay. And then the second part of it is you need to also be doing a lot of weight shifting. Okay. So, every 20 minutes, and I would teach my patients how to relieve the pressure on their bottoms, especially if you're having lymphedema in your limbs, right? If you have lymphedema, that's also going to make you more prone to having pressure ulcers. And you want to be aware of that. Okay. When it comes to building strength, yes, you need to have good upper body strength. You need to be able to push yourself up. Okay, so that your bottom clears the wheelchair. And that does take quite a bit of strength, especially if you're pushing down on a cushion. I'm having a hard time doing it myself right now because this is a pretty soft sofa that I'm sitting on right now. But having to really push yourself up to really allow that pressure relief on the bottom. Okay, when it comes to scooting yourself back, again, having to teach someone who doesn't have any control from the chest down, that can be very, very challenging. And sometimes even their arms are compromised in quadriplegics, right? Having to do different techniques on how to scoot yourself back. So if you don't have, a lot of times when I see people trying to scoot back in a wheelchair, they'll go like this, right? They'll push on their leg and they'll push back. Okay. What is that doing? Nothing. You're just hitting the back of your chair. You're not actually scooting your bottom. Okay. If you want to scoot back in your wheelchair, you actually have to lean really far forward and practice not falling out of your wheelchair. Nobody's allowed to fall out of their wheelchair. Okay. You lean really far forward. Why are you doing that? Because it's relieving the weight off your bottom. Okay. You're putting your weight forward without falling out. And then you're relieving the weight from your bottom. And at that point, your bottom is going to be weighing less and less anchored. And then you scoot back, do the boot scoot. We call it the boot scoot and boogie back when I was in Texas, right? You just scoot back like this. And that's a whole lot easier to do than pushing back with a leg. And it's much more effective. Okay. And believe it or not, guys, these are all skills that we work on in inpatient rehab and physical therapy and in outpatient rehab. Okay. Hey, Carolyn. Oh my goodness. It's nice to see you, Carolyn. Steve says what my wife does with iced coffee. Okay. Carl, good morning from Taiwan. Good morning to you. Let's see. Josh says I was a knee disartic for 30 years and now technically above the knee for the last 8. Emily says in weeks to months for that wound to heal unless you spend all your time laying in bed off that wound. Absolutely. Absolutely. So yes, Emily, in terms of building the strength, and let me go take it a step further. If you're a paraplegic or quadriplegic, there's not a whole lot of glute strengthening you're going to be able to do. You're not really going to be able to strengthen anything, but your glutes are intact, right? You have sensation, you have innervation to your glutes. So actually strengthening your glutes can help you be in a wheelchair. Okay. And the more sturdy your foundation, so it's not just about strengthening those arms, it is about strengthening the core, but also the glutes. Strengthen those glutes. That's going to be a part of supporting your core right there. Okay. Steve says, hey, Cozy, I realize there's a time frame when you say 8:30. It's 9:30 here in New York. I wonder if I'm the only one. I'm not sure. It's 9:30 here now. I did remember to do daylight savings time. So it is 9:30 here right now. So I'm not sure when you may have heard that. Disma says, good evening from Albuquerque. Good evening to you as well. Thank you for joining us. All right, let's see. Okay. Let's go. Okay. This question was very interesting. I have never had this question before. And I kind of just, it made me smile just a little bit because I'm just like, I it's just an interesting question. Oh no, Josh. Hey, I want to hear your input on that. Josh says, my bad. Thought you were talking about which situation was better. I joined late, apparently. No. Josh, would love to have your input. Yes, we were talking about earlier in the show the advantages and disadvantages to being a knee disarticulation compared to below the knee or above the knee amputation. So you have that very unique perspective for us, and I would love to hear whatever it is you might want to share with us about that. Van Gregory says, I often wonder if I would have a lot of loose soft tissue on my calves had I not been flexing and exercising them from day one of my amputations. More than likely good surgeries, though. They're pretty firm with what I consider no flabby loose skin on the distal ends. Bilateral BK as of 2021. I think it's both, Van Gregory. Certainly the skill of the surgeon. Certainly the skill of the surgeon. And guys, I joke around a lot about how like surgical techniques have not really advanced much since we just went chopping legs off centuries ago. But when you find a surgeon who really knows how to manage the soft tissue, it really does make a huge difference in the quality of life of the amputee, especially, with below the knee, is having enough soft tissue to pad the end of that tibia, but not too much that it then becomes a problem later on. So no, totally. I might give some of the surgeons a hard time on the show sometimes, but totally credit to where credit is due. If you have someone like yourself, Ann Gregory, who's had as much success as you have, yes, certainly because of all the hard work that I know that you do. Absolutely. But you started off, with good surgeries there. You took what you were given and you did something wonderful with it. All right. So this question right here, like I said, never had this question before. This lady says, I wear an above the knee prosthesis on the right and a hip disarticulation on the left. I was born this way. I am married and I have 4 kids, and I currently homeschool my 11 and 16-year-olds. Would you consider doing a podcast on ways to make extra money? And at first I was just like, I just didn't know what to make of this question. It's just a very interesting question. Okay, I can give you some of my thoughts on it. I certainly do not have the secret on how to make money. Certainly do not. Physical therapist, you don't become a physical therapist because you want to become wealthy. I can talk to you a little bit about my perspective as a mom, and a mom of 4, and a mom who works, and I have my own business. So as many of you know, I have 4 beautiful children, and they're very, very close in age. Early on, for as long as I can remember, I knew I always wanted to be a wife and a mother, and physical therapy came in third to all of that. So when I became a mom, my perspective completely changed. I loved what I was doing as a physical therapist, but I wanted to be a mom, and I wanted to be home. I did not want to utilize daycare. I wanted to be at home as much as I could with my child. So my husband and I worked very hard during these years of growing our family to make it work, so that I could be home with the kids. I always had some form of employment. I always tried to do some work as a physical therapist, working per diem, working home health, and just finding different ways that I could continue to keep up my skills, but still be the primary caregiver for my children. So my husband and I, we had very creative scheduling, and we made it work. We're actually going on 20 years of marriage in April. So we made it work, and I think we're doing a pretty good job. But there definitely came a time where working full-time days as a physical therapist was not going to be something I could keep up. And then I had cancer. Many of you know I had breast cancer in 2016, and that also threw another monkey wrench into the situation, right? So when I finished all of my cancer treatments and chemotherapy, and I was healthy enough to return back to work, I realized I couldn't keep doing what I was doing, right? The work scheduling was too much, and I had to just try to figure out something else. And that's when I decided to open up my own practice. Mind you, I had no formalized training on business, running a business, how to run a clinic, nothing like that. But it was something that I really wanted to do. I wanted to serve the amputee community. I wanted to be able to provide quality of care. Um, and a lot of things just kind of worked its way out over that. So 7 years later, I have this beautiful program that I get to do. I have lectures that I get to teach, and little by little, I've been growing the Cozy Talks brand and growing the business little by little and working it around my family, not the other way. I think a lot of times folks unknowingly try to build their family around their profession. And for me, I chose the opposite. So for this particular individual, she's a stay-at-home mom herself. She has 4 children. So one thing I would say to her is, find what is your passion? What is it that you feel like you have skills to do? Who is it that you want to be able to serve? And that was something that my parents definitely ingrained in me is, whether you're in a professional setting, a volunteer setting, wherever it is, who is it that you would like? How would you like to serve your community? Okay. And just start there. In terms of making the money, and this is something that my business mentor, I've had more than one wonderful mentor. He was also a father of 4, and he was the one who taught me how to open up my practice and how to make it work from a business and financial standpoint. That was the first thing he said to me is, who are you here to serve? Right. And make sure that you are sincere in those motivations, and you will find a way. And I think one of the cool things about social media nowadays is that we have so many ways of getting ideas on how we can be entrepreneurs, how we can be small business owners. And there's so many wonderful platforms to allow us to explore these things. Okay. But yeah, it kind of starts there. Make a list of what are your skills. Okay. And even if you didn't have any kind of formalized training, everybody has something that they're good at. Everybody has something that they have to offer the community and how you want to serve, and start there. But yeah, that was a very interesting question that made me stop and think for a moment. Okay. So Josh says, I will share through direct message because it will be way too long for a live. Josh, if you've noticed anything about my lives, there's no such thing as too long. Because I can keep talking. But as far as tonight is concerned, I think I have talked everybody out. We've answered. This has been a really fun discussion, guys. The whole knee disarticulation, I think, is something that we don't talk about enough. And it is certainly a part of the population that needs to be addressed. I'm actually going to get to hang out with one of my favorite prosthetists in the community. She and I are going to be hanging out all day tomorrow. I'm going to be a fly on the wall in her clinic. And just expanding on my skills and knowledge of alignment and all that kind of good stuff that prosthetists are really, really good at. So I will definitely be picking her brain about some of these questions for tonight and hopefully be able to bring you guys some more information next week. But in the meantime, actually, no, next week, whoops, sorry, my bad. Next week, my kids are on spring break. So speaking of mother of 4, I will be spending my time with my children all next week, and I cannot wait. I am so excited just to have this time with my children, my beautiful children, and my husband. So we're going to be doing that. But keep your eyes open. What I might do is if you guys have any questions, I might just do quick videos answering your questions. So just, keep an eye on the social media platforms this past week. And I will be seeing you guys not next week, not on the 19th, but on the 26th, if I did my math correctly. All right. In the meantime, guys, please consider either sharing this show to your support groups. If you haven't already done so, please follow the Cozy Talks on Instagram and subscribe to my YouTube channel. And also following me on Facebook if you're not already doing so. I humbly ask for the support, and I thank you ahead of time for it. Delcy, his name is Mark Hopkins, and please send me another email and I will get you his information where he is. And also, Delcy, in the email, you don't have to put it here publicly, in the email, let me know what area of the United States you live in, and I will do my best to find you the closest prosthetist possible that can potentially help you out. And in the meantime, for all of you who allowed me to be a part of your lives this evening, thank you. I wish you the best of luck. Those of you who are having surgery, those of you who have just had surgery, some of you who are celebrating some very special anniversaries today, and everybody who submitted their questions. So with that being said, guys, I will wish you a good evening. And I will see you in 2 weeks.